I'm really pleased. We have a distinguished faculty this morning. St. Louis is blessed with an incredible academic prowess, and we have tapped the departments of electrical engineering and electrical systems and Olin Business School for today's presentation. We will have three speakers. First is Dr., and I apologize for my pronunciation, Dr. Ari Necharai, who received his undergraduate BS degree at Nektian University in Israel, received his PhD at Stanford, then was on the faculty at the University of Illinois Chicago and Yale before joining Washington University. He has served as the chairman of the electrical engineering and the Department of Electrical and Systems Engineering at WashU from 2006 to 2016. He's the director of the Center of Sensory Signal and Information Processing and has co-appointments at 4 other departments at Washington University. He has received a number of awards for teaching at WashU and has served on a number of editorial boards. With him today are 2 graduate students, Yuri Goldstein, who also received his undergraduate degree at Technion in biochemistry, engineering, and electrical engineering, and is now studying for his PhD in electrical and systems engineering. He has a background in biomedical engineering and has done research in cardiology and is a virtual reality application developer. And Mr. David Schwartzman, who is a second-year doctoral student in the Business and Economics at the Olin Business School. He did his undergraduate degree at Hillsdale College and majoring in economics, applied mathematics, and finance. I had a minor in finance, and he is interested in health economics, focusing on healthcare and quality delivery. We have asked them because they have published their findings on opening our society in COVID, looking at both the economics and health impact on this. So I will turn over the podium to Dr. Necharai. Thank you.
It may not trigger strict responses for some people. I mean, it became a political matter of how to deal with it, because some people may believe that it's not such a major issue and there is no need to take strict responses. Also, this is a global pandemic and the world has become very connected, very much connected, which increases the danger in multiple countries. And for example, if you check it, you'll find that there have been hundreds of flights just from Wuhan direct to the United States in the last few months since the outbreak started. Next slide. So if you click on it, I believe you'll see a video of how the virus was spread. The goal of this slide is to illustrate that even though there were travel restrictions, still there were a lot of movements outside of Wuhan since the outbreak began, and it illustrates how quickly, because of the connectivity in the world, how quickly the disease was spread, not only in China but around the world. You can find that only a single individual infected many people, according to government data. Can you go to the next slide? Because it is a new type of pandemic and there is not enough data, it becomes very challenging to do precise predictions. But on the other hand, as time goes on, there are more and more data available to enable more precise modeling and predictions. And indeed, there have been a lot of publications, as you see in the bar diagram here. In the last few months, you can see that the articles about COVID-19 indexed on PubMed have increased significantly. we are going to use advanced tools to model the pandemic based on previous models and our extensions. Next slide, please. So different models are used for different purposes. For example, they're used to focus the pandemic evolution or to understand the dynamics behind the spread. And in particular, related to our research, they can enable the best policies of quarantine in order to minimize the health and also the economy risks. Next slide. As I mentioned, there are challenges, including the lack of data, especially in the beginning, which can make the models provide incorrect results. And also the models themselves can influence public policies, which may change the effects on the ground, meaning that we will need to use new models as changes are made. But on the other hand, models are very important for providing predictions and helping policy making. And as it turns out, even if different researchers use different models, very often the results are similar. So this is true for our case. After we posted our research manuscript, there were others who dealt with some topics related to us, but came up with similar results. Next slide, please. Next slide. In the beginning, there were some research publications by, for example, the Imperial College in London and some others. This was around mid-January. The purpose of those models was to estimate the number of cases and the severity of COVID-19 in China. But because the research was done very early and there was not enough data, the results were not precise, and also not much attention was given to the results because it was at first localized in China. But after the number of deaths increased and the infection spread around the world, then the models got more attention. Next slide. I'm just giving you a background of different models before we will focus on our model. So there have been different kinds of models used to analyze the pandemic and predict the results. So estimation models are statistical methods that analyze the spread, for example, the transmission rate, the case fatality rate, the number of infected individuals. Forecast or prediction models are used to predict, for example, the expected number of deaths, number of hospitalizations, ICU beds that are needed. Genetic models study the virus origins and mutation rates, could be useful, for example, for developing the vaccine. Next slide. Contagiousness models, they study the contagion mechanisms, the dynamics behind the evolution of the pandemic, and consider interventions such as wearing masks and effectiveness. Economic models focus on the effect of the pandemic on the economy. For example, the impact on the stock market, changes in supply and demand dynamics. Then there are evaluation of interventions models, non-pharmaceutical, and these are associated with trying to find the best public policy and the best timing. Next slide. The most common models used to analyze the evolution of the pandemic are called compartmental. Compartmental models come from physics, but they have been adopted in epidemiology. And in our case, they represent each compartment represents a state in the disease progression. For example, the susceptible, infected, hospitalized, recovered, and dead among different groups of people, the effect of the pandemic on different kinds of people. So the mathematical model of the interaction among these compartments described through differential equations. We're not going to show equations, but just giving you the general background of what the compartmental models mean. And interestingly, as a result of the compartmental models, many basic concepts came out that you will hear about today. For example, the factor R0, the herd immunity, flattening the curve, etc. Next slide. This is an example of a simple compartmental model to simulate the spread of COVID-19. And you see here 3 compartments only for this simplified model. You can see that this is a feedback system. In this illustration, just to illustrate the concept, we have the group of susceptible affecting the infected. And among the infected, there are some who are recovered. And you can see the feedback from the infected back to the susceptible through the contact rate that affect the susceptible that makes him infected. Vaccination can heal the susceptible or prevent them from becoming ill in the first place. Next slide. So, as you saw in the title of the talk, we are going to model the combination of economy and health effects related to different policies, quarantine policies. And we will have some specific results about the best choices. So, the interest in this is because obviously there is a conflict of interest. On one hand, we would like to heal or prevent people from becoming sick in the first place as much as possible. And this could be done, for example, through very strong quarantine policies, as has been done in China. On the other hand, if we use strong quarantine policies, at least at this stage in the US, then it would have a detrimental effect on the economy, which causes this conflict of interest and the need to find the best balance in the outcomes between the health and the economy. Additionally, we know that the pandemic affects different groups in different ways. In particular, seniors are more affected than non-seniors, and CDC data shows that 80% of the deaths so far have been among the seniors. So before our work, there has not been such research about both the inclusion of both health and economy outcomes associated with different policies, and also the fact that the pandemic affects the seniors differently from non-seniors also was not included. So therefore, this motivated our research to integrate the economic and disease spread related to the different policies and trying to come up with the best scenario. We are going to see this soon. So this time, I believe, Uri, you're going to go with the next slide, right, Uri?
Okay, thank you. So as every model, there are assumptions. These assumptions are true for compartmental models in general and to our models in particular. First, we assume that all individuals in every compartment are equal. One of the main challenges in compartmental models is that they cannot easily model individuals. There's some effects like super spreaders that need to be averaged over every compartment. We assume that individuals cannot get reinfected. After they get infected, they develop some immunity, at least in the short term. We also assume that the population is isolated. We assume that there's an initial input of infected individuals that start the outbreak, but after that, there's no contacts with other society. This is true as we are isolated and there's not much air traffic, but this will not continue to be true forever. And then we also assume that the disease progression is identical for individuals. We take an average of how long does it take to move from different stages of the disease. Next slide, please. One of the interesting concepts that stem from the SIR model is the reproduction number, R. R describes how many individuals become infected due to a single infected individual. This R number changes over time as interventions evolve. And the idea is that with better interventions and less susceptible people, R decreases. The smaller they are, the less problematic is an outbreak. In particular, when R becomes smaller to 1 for a long period of time, the number of cases keeps declining continuously until the outbreak is controlled. And eventually a disease can become endemic if the R it keeps below 1. Next slide, please. A particular concept that's been researched a lot and talked about a lot in the news is the R0 parameter. R0 is the idea of R only in the case where there's no interventions or behavioral changes, or even herd immunity. It's a biological parameter of the disease, so it's intrinsic to the particular disease. And it's usually observed only at the very beginning of an outbreak. This is probably what we saw in the first weeks or months before any public policy was taken to control the spread of the disease. And different studies assume it to predict it to be somewhere between 2 and 4. And as you can see in the figure below, there's a comparison of different R0 for different common diseases. Next slide, please. Policies to limit the spread. There are different kinds of policies that have been used and been proposed to control the spread of the disease and therefore reduce the R number under 1. The most strict ones are lockdown policies, where this can either be broad to the general population, as has been seen before, or targeted to specific higher risk groups, as we'll see afterwards. In these policies, the population is not encouraged or allowed, depending on the implementation, to leave their houses unless necessary. These are the most seen to be the most effective in preventing the spread of the disease, and also have the largest economic damage. And they're usually necessary when the outbreak is poorly controlled and there's no possibilities of doing more advanced and more fine-grained mitigation policies. Then we have mitigation policies that lessen the risk of interactions rather than completely shutting down the society. These include wearing masks, limiting indoor activities, and keeping distances between different individuals, as an example. Next slide, please. Lastly, there are even more fine-grained policies that include test and trace. And this is including similar things to contact tracing that we have heard about. And the idea behind these practices is to just control the people that are being infected, as opposed to controlling the entire population. It's even more fine-grained than the mitigation policies. Random testing of the general population has been done in some countries, and the idea is to keep track of the evolution, and it's useful to close and open different parts of society independently. More mitigation and trace and test and trace policies are allowed to move away from lockdown, and the idea is to eventually, for the long term, try to move from the more strict policies into the strict policies while keeping a good control of the disease. Next slide, please. Another concept that stems from the SIR models, or is explained by SIR models more correctly, is herd immunity. The idea behind herd immunity is that if enough individuals in a society have developed antibodies or are immune to the disease, and they cannot get infected. Interestingly, it was observed before that it doesn't need to be the entire population that's resistant to it to give a protection. But when most of the population is resistant, there's no possibility for an outbreak to take place. And this herd immunity number, the number of individuals needed to be immune to the disease to give the immunity, can be calculated from SIR models. It's estimated for COVID-19 to be around 60% of the population. And as you can see in the diagram below, most cities are really far away from that number. Even New York, that was really hit, and one of the cities with most rates of infection, still is a long way from the 60% needed. A rough calculation suggests that getting to herd immunity by letting the entire population getting infected, as some politicians have considered or suggested, and would lead to somewhere between 1.5 and 2 million deaths due to coronavirus. And so therefore, it's not a feasible approach. Next slide, please. And the role of a vaccine that has been heard a lot is to shortcut the pathway to herd immunity, to move people from the susceptible compartment to the recovered compartment. Although it sounds interesting, the development of vaccines is expected to take at least 1 year. And then even when we had these vaccines, to do a vaccination campaign for the entire population would take a very long time, probably a few months. And as even for the development, as you see in the diagram, even though there are a lot of approaches, only few pass each stage. And therefore, we can only count on the vaccine as a long-term solution that would eventually, when it's released, help control the disease, especially if the immunity is not long-term. And therefore, we need to develop non-pharmaceutical interventions to control and even eradicate the pandemic in the near term, and develop a whole range of approaches that do not rely on the vaccine, at least for a while. Next slide, please. Our contribution. We expanded the model, the classical SIR model, to adapt and reflect more of the characteristics of COVID-19. And we use it to study different policy, public policy. And as you can see, in particular, we were interested in policies that protect the senior population more than the non-seniors. And since those have a higher case fatality rate and tend to have a larger number of hospitalizations in proportion to the non-seniors. In our model, briefly, as you can see below, it's also a compartmental model where the susceptible individuals move into exposed individuals and then to infected. The difference between exposed and infected individuals is that exposed individuals will eventually be infected, but currently are not contagious. This is important because this adds a lag in time between the time a person gets infected and actually gets reported in statistics as being infected due to testing, because they show symptoms and get tested eventually. And that implies that the data we currently see daily is always inherently a couple days old. This infected can then be either asymptomatic or eventually become hospitalized, as you see in the yellow box. Hospitalized patients can then either die or be recovered, as same as asymptomatic individuals in the box below. And on parallel to all the upper states, which are the more classical SIR models, we included the lower states, which take people into quarantine and social isolation, and that kind of prevents the individuals from circling through the progression of the disease. Next slide, please. And what are the inputs for other models? We used estimates of disease parameters for different age groups that were released as of April 2020, this April. We focused mostly on peer-reviewed reports from around the world. At that time, the reports that we were getting were mostly from Asia and Europe. We divided the population into two main age groups and economic groups. The first one is either below or above 60 years old. That's what we call our high risk and low risk. This is a haircut, and as we mentioned before, in compartmental models, we need to make generalizations of the population and aggregate it into groups. The second group were people that get affected hardly from working at home, and those who are not affected that much, their work does not get accepted that much by quarantine policies. The data for these groups was taken from previous reports from the United States. Next slide, please. Another interesting aspect we've seen and we've included in our model is the improvement in treatment over time. As more case studies and reports are being published, better therapeutic options are developed. And these improvements are firstly driven by non-pharmaceutical interventions, and eventually will switch to pharmaceutical interventions when they become available. And this should be a driver to slow the spread of the disease, so we can have most patients be infected at the time when the therapeutic options are available. Next slide, please. And I hand in this presentation to David.
So what we do is we use the model that we develop and we look at 3 different scenarios that are potential public policies in terms of lockdown policy and weakening the lockdown over time, depending on policymaker preferences. And so all of these policies, they're aimed to balance the spread of the disease with economic impact, and the different policies can just come from different priorities of the policymakers about how much they prioritize each one. And so these policies also, they're not just general to the entire population, but really key to them is that they are different for the older population and for the younger population. The older population is higher risk from the disease, and also they're disproportionately retired. So they aren't contributing to as much of the economic productivity as compared to the younger groups. So kind of evaluation policies that are targeted to them can be more effective in terms of decreasing the death and the spread of disease, but also being less damaging to the economy. And so the population we simulate everything on is about 330 million, similar to the United States, and it's over 76 weeks, which is just a proxy until the approximate development of a vaccine. But you can kind of make the time period somewhat smaller or larger, and that doesn't really affect the results. So next slide, please. So our baseline scenario is basically taking the strict restrictions that were put in place in March and just having them indefinitely until the end of the pandemic. So that's, for us to put a proxy on that, we use 85% of non-seniors in quarantine and 95% of seniors. And the reason that it's this percentage that's in quarantine is because you're never able to quarantine everyone, just because there's a lot of essential workers that are necessary to the functioning of society, and there's just never a way to increase the amount in quarantine. And so what we see there is it's the strictest possible scenario in terms of controlling disease spread. So it minimizes the deaths from the coronavirus, but you still see 210,000 deaths in this scenario. And with these really strict lockdowns that we have simulated, it results in not a lot of deaths among seniors, 30,000. And a lot of the deaths are the people in the population who are essential workers, who are being exposed, and so more of them are dying. So you see 210,000 deaths. And the economic damage in this scenario is very high because you have the most people in quarantine, they can never exit quarantine. So you see the productivity shrink by 34%. Next slide, please. So the next scenario we look at is one where first you have the strict quarantine, and then you bring the disease spread more under control, and then you loosen the restrictions very quickly on non-seniors. So we use as a proxy under 1,000 infected individuals, and then we just release all the non-seniors. And so even here still, we're keeping the seniors in quarantine because they're at such high risk. But even when you keep them at such high risk, if you release all the non-seniors very quickly, what you see is first, economic productivity is rapidly increases to almost before the pandemic levels, but very, very quickly you see a second wave take place and you see many people die and you see the reimposition of the quarantine restrictions. So in this scenario, the economic recovery still isn't even that large and you see a lot of deaths. Next slide, please. So here you can see a graph of kind of the disease dynamics in this scenario, and you see that there's a massive spike in the number of infections and deaths that necessitates immediately putting back in the restrictions. And you see that initially the economic productivity recovers quite a bit, but almost immediately you just need to reinforce the restrictions. And so you do see some economic improvements as compared to the strict lockdown the whole time, but it's really not that large. And you see many, many, many more deaths. And you also see that even though the seniors are being mostly locked down, a lot more of them die, even though the restrictions on them aren't even lessened, just because of the interactions with the people who do have the relaxed restrictions, who are not seniors. Next slide, please. And then the third scenario that we look at is a gradual release of non-seniors. So similar to the sudden release, we're first keeping the restrictions in place for a period of time until the infections are brought relatively under control. And then rather than just releasing everyone at once, you have a gradual release where we use for gradual release about 0.1% daily being released from quarantine. And so if you want to think about that in real world terms, that's something that would be analogous to maybe one industry being released at a time, or particular risk groups being released one at a time, versus the sudden release is just all non-seniors can go back to work immediately. And so in this scenario, you see 220,000 deaths, 34,000 among seniors. So that's about 10,000 more deaths than in the strict lockdown case. So not too many more deaths, and you see that the economic productivity decline is 29% instead of 34%. Next slide, please. So one thing that's very important to note is that key to all of our simulations and all of these approaches is that the seniors' restrictions are not being relaxed in any way. They're the people who are at high risk. And so if the restrictions on them are relaxed, then the number of deaths increases substantially. And so it's important to keep that in mind. And the thing is as well that lifting quarantine policies can send a signal that now the situation is less serious. And even if lockdown policies are not lifted for seniors, if the changing quarantine policies result in them kind of modifying their behavior themselves to go out more, then there can be really devastating effects. So it's really important to make sure that the lockdown restrictions are very strict on the seniors, and that the messaging to them is that the situation it's very necessary for them to continue to be locked down. Next slide, please. So here is just a graphical comparison of the results in the three different scenarios. So you can see the number of non-senior deaths is fairly similar between the between the baseline and the gradual release, and the sudden release has many more deaths, substantially more deaths. And that's true for all deaths, and that's especially you can see in hospitalizations. You have an incredible amount of hospitalizations if you just release everyone at once, and you have a lot more similar levels of hospitalizations in the other two cases. And in terms of productivity, the economic impact, you can see in all of these scenarios, the economic impact is devastating. Just because lockdowns are this kind of measure that you just get very devastating results. But you see that between the sudden and gradual release, there isn't too much economic difference. Both of those are quite a bit better than the strict lockdown. But even though the sudden and gradual release, you see not very much difference in the economy, you see many, many differences in deaths. So a lot of times we think about this trade-off between the economy and the health outcomes. But really, if the disease is poorly controlled, there isn't really too much of a trade-off, because you can't have the functioning economy when you have the poorly controlled disease. And that can even necessitate longer restrictions that can be worse for the economy. Next slide, please. So the other thing that we look at is kind of, as we mentioned, the R, that spread of disease, it changes a lot through time. And so we want to see how would our model look different if we're looking at different values of R. And so that's something that could happen through various mitigation policies that could lessen infectiousness. And so you see that when you lessen the R, then there can be massive improvements to the number of hospitalizations and deaths and economic outcomes. And that's also something that could potentially lead you to different lockdown policies, which could further improve the economic outcomes. So you can see that it's extremely important to look at interventions that mitigate the disease spread. Next slide, please. And so another thing we look at the effect at is how strictly are the quarantine policies being enforced, and how would that affect changes? So to what extent are policymakers being strict when they're choosing to bring people out of quarantine or put them in quarantine? And so you see that the stricter the quarantine policies are, the less hospitalizations and deaths. When you have this just completely airtight quarantine, then it's a lot difficult for the disease to be spreading. And you also see that when you do that in that airtight way, that the economic damage is much higher. But you also see that even when you're not really being airtight at all, there's still a large amount of economic damage. And there's really no way to have lockdown policies that don't have profound economic damage. And there's really no way to, without bringing the disease under control, do something about the severity of the economic damage. Next slide, please. So we kind of, based on our findings, we conclude a few major points. One is that if you just take this baseline from March of strict quarantine for everyone, strict lockdown, then the economic productivity is very low and the number of deaths and hospitalizations is minimized. If you do a rapid reopening, again, only for the non-seniors, there's a second outbreak and many people die, and then you need to reinstitute the quarantine restrictions. And so the economic recovery is reversed in this case, where you have a very short-term increase of economic productivity, but it's very short-lived and you just need to reinstitute the restrictions. And then this kind of third option where you do a slow gradual reopening for non-seniors doesn't have too many additional health effects, but it does have relatively substantial economic effects. Next slide, please. So 3 major recommendations that we take from this is that, 1, we see that there's a lot of economic damage no matter the policy, so it's really important to bring the whole situation to a close and invest in development of vaccines and more effective treatment options that make COVID less devastating. Also, enforcing quarantine measures for seniors is extremely important, and minimizing their exposure is extremely important. And thirdly, in terms of the quarantine policies, it's important to prevent the second outbreak from occurring in order to prevent the increase of deaths. And the way to do that is a gradual release of non-seniors. Next slide, please. And can we pass it back over to Professor Nehurai?
There are a number of ways that we can extend our research to get more accurate results and more specific to different groups. We plan to refine the model parameters based on new knowledge and new data. And also, we would like to include other groups besides the seniors which are at high risk. For example, people with underlying conditions or people at lower socioeconomic strata. And if there will be more testing, then the new data will enable more specific, more targeted policies. And the last one is we did not include the fact that different groups may have different reaction to long isolation, and this may affect their behavior. For example, based on some boredom or some mental illnesses or protests that may make them less cooperative, and they will not follow the quarantine policies. So these kind of different groups are interesting, and we could expand our model. And in fact, we are already working on including the different groups that have less access to healthcare system. And next slide. So this is an unusual time, and it calls for maybe unusual for me for thanks. In this case, I'd like to express our thanks to the healthcare workers for their tremendous efforts, and not only that, risking their lives to help other people to fight the pandemic and heal the sick people. And we'd like also to honor those who lost their lives in this fight. It's unfortunate that we have come to this point, and you can see that our research shows that there could be good balance between the economy and health. In other words, it's not either or a situation, and we hope that people pay attention to the science and follow the guidelines based on science, which I think actually makes sense. I think the results that you saw today, I believe that it makes sense to, if not all, I would say most people. So next slide. If you have questions, we'll be happy to answer.
Well, thank you for an extremely excellent presentation. All three speakers have done exactly what we had requested, so I thank you. I don't know that I mentioned...
Any questions from the audience?
Yeah, well, we're going to get those in a second. I don't know if I mentioned to the audience that the speakers are all in their own offices. We're doing this all remotely today. So we've got a couple of infectious disease experts here in the office. Do you have any questions?
I see there's a question in the chat.
I don't see the chat. So what is the question?
The question is, what would we recommend for physicians who are over 60 years old? Precautions that all primary care outpatient practices should be following?
So what would be a policy for physicians who are 60 years old or older, right?
Yes,
correct. That's a very interesting question. And it could be, in principle, I think it could be included in the expansion of the model. I mentioned high-risk groups. With the physicians, it's more challenging in a sense that on one hand, they belong to the high-risk group. On the other hand, they are critical for the healthcare of the sick people. So it is a very delicate balance, I would say. I think in principle, we could include it in the expansion of the model. Very, very tricky question, very challenging question.
A couple of others that it looks like you had commented on the fact that you could, this is a dynamic model that you can adjust. Any thoughts about looking at new data from Europe or US, East Coast, West Coast, rural versus urban areas in the United States?
Yeah, this is another very good question, because you probably noticed that the data that we used is only from the US, and actually most research is assuming the same that we assumed, namely more uniform population and no differences between different cities or how they interact with each other. But definitely there is a need to do such research. And I totally agree that there is no way to solve it in one country only, let's say in the US only.
And then,
David, you want to say something, Uri?
Yes, I would like to add something to that question. Something we actually started looking into is the issue that we've seen in, particularly here in the US, where there's a lot of data actually, and it's the effect of socioeconomic positions on the spread of the disease, both in terms of mortality and spread. We see that there's a high dependency on how much the disease spreads and its outcomes based on socioeconomics here in the States. So that's something we would like to incorporate here.
And you gave 3 examples, but it looks like your model could probably be continuous. I mean, you could do this in continuous variables so that you could take different cut points. Essentially, that's what it looks like you did, was take separate cut points. Is that true?
Yeah, this is true. We could do what you suggested, but we would need to have data. One reason we chose the cutoffs is based on the availability of data.
Well, most of us understand the cut points better. The continuous would be much more complicated. And then anything on the test trace isolation model, where you test broadly, you trace broadly, and you isolate just those folks that are at risk specifically.
Uri, David, you want to answer?
Yes, I'd like to answer. And that's a policy that's being implemented in several countries right now or being thought on. It can be very useful, but only once the disease is strongly controlled and the measures are really well done. What we see, the issue on one of the failures we had with this disease was that when in China started getting tested, the disease was already much larger than what initially thought. So the risk with test and tracing is that we could have a second outbreak and it would only be identified later on in time. So that early delay has been shown by others now that's very, very critical. So it's necessary that before doing a test and trace approach, we have a strict control and reduction of the number of cases.
Any other questions? I would really like to thank the 3 of you. You've done an outstanding job. It's exactly what at least those of us that were planning this asked for. I didn't know that I mentioned that all of our speakers are at their own safe social distancing. They're not in the auditorium. We have been extending our use of technology. Thank you all again for just a wonderful presentation.
Thank you for inviting us.